intrauterine growth restriction. So let's talk about it. First is high risk pregnancies. Intrauterine growth retardation due to preeclampsia. So now we will call it restriction. Red blood cells isomerization, maternal diabetes mellitus, preterm pre-labor amniorexius, maternal autoimmune disease, twin pregnancies. These are all high risk, and as we can see, the first in the list is IUGR. Preeclampsia and IUGR associated with an inadequate quality and quantity of the maternal vascular response to placentation. So when the placenta is in demand of vascularity, the proper quantity of blood and the required quality of blood is not being supplied by the maternal vascular system, which can result in inadequacy and then ending up in preeclampsia, which can lead to few abnormalities, and the top of list is IUGR. Another term is very important to know, which is hypoxemic hypoxia. As we know, hypoxia is decreased availability of oxygen to the fetus, especially when we are talking about the UGR, reduced placental perfusion with maternal blood flow. So there is decreased or diminished placental perfusion with maternal blood flow and consequent decrease in fetal arterial blood oxygen contents due to low PO2. IUGR, intrauterine growth restriction, describes the fetus who has failed to reach its own theoretical normal growth potential. It can be mainly of two types, symmetrical and asymmetrical, or we call it symmetric or asymmetric IUGR. In symmetric IUGR, growth rate decreases from early in pregnancy with a sustained low rate. So the rate of growth is decreased, resulting in growth rate which is decreased. These infants are usually small, presenting reduction of all their external measurements. As the name shows, it is symmetrical IUGR. So symmetrically, whole of the body is small as compared to the dates. So BPD, femur length, abdominal circumference are measured, and everything is smaller than the required size at that specific gestational age. In this case, growth decreases from early in pregnancy with a sustained low rate. These infants are usually small, presenting a reduction of all of their measurements. The symmetry has important prognostic implications as it relates to whatever primary process is limiting fetal growth and the potential functional damage that may follow. So there is something from the inside the patient, like if the fetus has got some infection or any reason which makes the fetus sick, can result in slow growth rate of all the structures of the body as compared to its gestational age. Its appearance or its diagnosis will be earlier. We can diagnose it at about 20 weeks of gestation. In symmetric IUGR, we can have intrinsic conditions, intrauterine infections, exposure to drugs, active early in pregnancy. Symmetric IUGR is seen with extrinsic conditions or with intrinsic embryonic conditions. So, intrinsic embryonic conditions are more important. That's why we can see its onset earlier. Obviously, there are some extrinsic factors we will discuss. Intrinsic embryonic conditions can be genetic causes, congenital anomalies, or infections. Whereas asymmetric IUGR, the overall pattern of fetal growth in these cases is typically normal until late in the second or early in the third trimester. So the onset is usually at 28 weeks of gestation. The head circumference and femur length are relatively normal in size for gestational age but reduced abdominal circumference. So the femur and head is growing, but abdominal circumference is less. That will indicate asymmetrical IUGR. Asymmetric IUGR is result of uteroplacental insufficiency secondary to extrinsic factors. And in asymmetric IUGR, the fetal asphyxia is often terminal event. So any fetus having asymmetric IUGR can end up with asphyxia. We can say that asymmetrical IUGR is mainly result of uteroplacental insufficiency secondary to extrinsic factors like hypertension, diabetes, mellitus, etc. The asymmetry is perhaps the result of predictable adaptation of the fetus to sequential deprivation, and fetal asphyxia is often the terminal event. So, as the fetal head is normal, almost normal, due to brain sparing phenomena, the growth restriction is usually seen in abdomen. That's why we diagnose it by measuring the abdominal circumference mainly. Although nowadays there are many other things which we can measure, we will discuss in this presentation. On B mode, first thing is biometry, and biometric defects are important. Biometry, which is also called phytometry, is the measurement of different structures or different parameters to predict the gestational age, like BPD, head circumference, abdominal circumference, femur length. These are commonly used parameters, and then we can use intraocular space space between the orbits, the length of the foot, humeral size, tibial size, etc. We can also predict the gestational age with the measurement of cerebellum. So on B mode, biometric assessment is important, whereas on color Doppler, we do the assessment of pathophysiology. If we look at the assessment of uteroplacental insufficiency on color Doppler, it helps to identify those fetuses that should be more frequently monitored to avoid fetal demise. So color Doppler is very beneficial in having diagnosis and follow up when the diagnosis of uteroplacental insufficiency or IUGR is already established. So we need to follow them. We need to keep an eye on them. So keep on monitoring so that we can avoid fetal demise. We can take steps to deliver before the fetus goes to asphyxia. Doppler effect is very important. We know that the sound waves they travel towards the vessels, and in vessels the RBOCs are moving with some velocity. So when the sound waves strike a moving subject, the pulses, the echoes we will be getting on color Doppler will be different from the echoes we will get from static structures. Then are the measurements like resistive index or resistance index. We have pulsatility index, the PI, peak systolic velocity, end diastolic velocity, and time averaged maximum velocity. These are the measurements which we usually take at spectral Doppler. The sequence of pathophysiologic process in IUGR can be described as number one is decreased fetal growth. This is followed by abnormalities of the blood flow in umbilical artery and fetal aorta, as well as vasocentralization, that is brain sparing effect. Then the next step is if pathologic process continues, there will be reduction in the amniotic fluid volume as a consequence of blood distribution and reduced GFR. Finally, venous blood flow will become abnormal, followed by the CTG abnormalities. For fetoplacental vessels, you can see the aorta. We look for the aorta, ductus venosus, and IVC. So fetal arterial blood flow, fetal venous flow, and uteroplacental units are assessed. This is the power Doppler in the placenta. So the arteries which we assess to confirm the IUGR, which is diagnosed with the help of B mode and photometry or biometry. In order to confirm it and to get the details, we use color Doppler. And with the help of color Doppler, the first three arteries which are assessed in the fetal body are the umbilical artery. Here is the early systolic, peak systolic, end systolic. End systolic is the early diastolic and end diastolic. Usually it is sawtooth appearance, but it varies with the gestational age. Normally, the diastolic has to increase with the advanced age, but if it keeps on decreasing, that will be abnormality. Here is the fetal aorta, and this is the waveform, the signature of fetal aorta. And then we come to middle cerebral artery. In 1977, any Doppler system like CW and PW the difference in measurements depending on the place used for the measurement, insertion, or free loop. So in 1977, we had no Doppler. It was introduced in the 1980s, early 80s. So we were relying on biometry and grayscale measurements. Then we got CW and PW, and we will have umbilical artery Doppler from the free loop that will be better as it varies at its insertions. Dependent on placental resistance, so we measurement method not important. We measure PI, pulsatility index, resistive index, or systolic diastolic ratio. There is the peak systolic velocity, and then we have the end systolic and diastolic velocity. So we need high end diastolic velocity in normal. There will be low resistance. As the resistance increases in the umbilical artery, the diastolic goes on decreasing. Absent in diastolic flow in the first trimester, an increase in diastolic velocity with gestation. We look at the chart, the week of gestation versus SD ratio, RI and PI. 20 to 23rd week, the SD ratio is 2.8, then RI is 0.6 and PI is 1.8. 24 to 27th week, SD ratio is same, RI is same and PI decreases. 28 to 31st week, 2.5 is the SD ratio. RI is 0.6 and PI average will be 1.5. So PI is decreasing with the age, whereas RI remains almost 0.5 to 6. SD ratio must be above 2 and less than 3. It is the umbilical artery and vein. When it is abnormal, increase of the resistance for gestation. When the resistance increases, the diastolic decreases. So it is going down, and we can have absent diastolic, and we can have reversal of the diastolic. So absent or reverse end diastolic flow is indicative of abnormality in the umbilical artery. Here you can see the normal. With gestation, as I mentioned, it will keep on increasing. Absent and end diastolic velocity, and then is the reverse. When we get reverse end diastolic velocity, that indicates severe IUGR or hypoxia. And if we get phasicity in the umbilical vein along with reversal of diastolic flow in the umbilical artery, we label it as asphyxia. When we look at abdominal, then we were discussing the umbilical artery, then comes the fetal aorta. We take a sample at the level of diaphragm. It is descending aorta. Decrease of the resistance from the aortic arch towards distal parts. We will take its sample. Fetal aorta is the largest and most easily accessible straight fetal vessel, and measurements are obtained from the descending aorta just above the diaphragm. There is a decrease of the resistance from the aortic arch towards the distal part. So the resistance is decreasing as we are going down along with the descending aorta. We are talking about the aorta of fetus. Here we have aortic spectral Doppler. This is the normal blood flow in fetal aorta. We have got the SD ratios RI and PI of fetal placenta here. You can see the SD ratio is 4.3 to 4.5 at different weeks. RI is 0.7 to 0.8. Umbilical artery RI was 0.5 to 0.6, varying in different ages. Here the resistance is a bit more as it is fetal aorta. PI is usually 3 times to RI as an average, so we can correlate them. The ratio between RI and PI is usually taken normal when it is 2.5 to 3 times. I mean, the PI is supposed to be 2.5 to 3 times of RI in all body structures, even in fetus. Impedance constant throughout gestation. PI is 1.96 plus minus 0.3 standard deviations. Diaphragm level. PI 1.68 plus minus 0.28 SD renal artery level. So at fetal aorta, you can see the absent diastolic flow. Let me take you back to the normal flow. This is the normal signature of fetal aorta. Systolic, diastolic. This systolic is almost 4 times to diastolic. How I can say 4 times? Here is the ratio. 4.3 means systolic is 4.3 times to diastolic. This is diastolic and here is the systolic. So in the beginning it will be about 4.3 times, at term about 4.5 times. So the systolic will be about 4.5 times as compared to the diastolic in fetal aorta at term. So if you know this thing, that it must be around 4 times, when the ratio between systolic and diastolic is affected, or even the diastolic is absent, that means that the fetal aorta is having problem. The resistance is getting problem. And condition which is even worse than this condition, that the diastolic is absent, we can have a reverse blood flow. The reverse blood flow, again, as we saw in umbilical artery, is indicative of hypoxia changing into asphyxia. So first thing we saw was umbilical artery. The normal waveform we saw, this SD ratio is about 2 to 3 times. It means in the beginning the diastolic will be a bit higher. With advancement in age, the ratio will be 1:2. It means the systolic will be almost double of the diastolic. But if it decreases instead of increasing, we saw that there will be abnormality, indication of early IUGR. If it is diminished, it will be late IUGR or hypoxia. If there is reverse, it is going from hypoxia to asphyxia. Similarly, in aorta, we know the ratios. There is the normal ratio here. If you see, this is aorta. Here you can see the 1:4. 4 is systolic and this is diastolic. So again, like umbilical artery, if it is decreasing or absent, is IUGR, and if it is reversal, it is hypoxia leading to asphyxia. Then we come to fetal cerebral blood flow at circle of Willis for the middle cerebral artery. For cerebral vessels, we place the transducer at the base of the skull. Different characteristic dependent of the myed blood vessels due to their origin, vertebral or carotids, mid-cerebral artery vessels of choice, easy to find, most representative. Normal blood flow in the middle cerebral artery. This is the normal blood flow. There is present diastolic component, but no marked diastolic and diastolic flow. Better brain oxygenation in IUGR cases. If the patient is having, if the fetus is having IUGR, we can have brain sparing phenomena in which we will be able to see the middle cerebral artery seems to be normal as compared to the other vessels like umbilical artery and aorta of the fetus. When there is blood flow redistribution, so it is in the start of the IUGR, When there is redistribution, the brain sparing effect occurs and decrease of the resistance is seen. So as the resistance increases due to IUGR, the body commands, the nature commands for brain sparing effect that is done by decrease of the resistance in the vessels like middle cerebral artery. We can do direct assessment of fetal oxygen. Here it is, the peak systolic velocity, and then this is the end diastolic velocity. Fetal death or irreversible brain damage can also be assessed. There is a term called ARED flow. A is for absent, R is for reversed, E is end, and D is diastolic. So absent or reversed end diastolic flow in the umbilical artery or in fetal aorta. In severe cases of IUGR, 98% of fetuses with ARED show evident signs of asphyxia. So if we have end diastolic or reverse end diastolic or absent end diastolic flow in umbilical artery and fetal aorta, 98% of fetuses are indicating asphyxia. ARED indication for intervention. Whenever we get absent or reverse end diastolic flow in these two vessels, it is an indication that we have to intervene. Surviving fetuses with increased incidence of necrotizing enterocolitis caused by fetal vasocentralization and intestinal vasoconstriction. This is umbilical artery with reverse, fetal aorta with reverse. Spectrum is upside down. Then is the middle cerebral artery, degrees of resistance, indication for termination of pregnancy. Redistribution of well oxygenated blood to vital organs such as brain, heart, and adrenals. It represents a compensatory mechanism to prevent fetal damage. When the reserve capacities of the circulatory redistribution reach their limit, fetal duration may occur rapidly. So there is a limit of redistribution. If the damage crosses that limit, then the deterioration of the fetus causes rapidly. Other fetal vessels are femoral and iliac arteries, of no use in fetal assessment. Splenic artery, hepatic and mesenteric vessels. Blood distribution exists but of no use in assessment of fetal well-being. After three arteries means the umbilical artery, fetal aorta, and middle cerebral artery. Then comes evaluation of the fetal venous system for IUGR. It is more subtle and complete picture of fetal circulation. When there is alteration in arterial blood flow, venous return from placenta to umbilical vein to ductus venosus to inferior vena cava. So it means when the aorta is disturbed, umbilical artery is not properly giving us the normal signatures, or there is brain sparing phenomena, there will be effect on these vessels, on the venous channel of placenta, the umbilical vein, ductus venosus, and inferior vena cava. So we see all four things to have venous assessment of a fetus suspected for IUGR. 50% into liver, 50% into ductus venosus. This is IVC, normal pattern of IVC, normal signatures, and normal signatures of ductus venosus. In the umbilical vein, normal is continuous flow which becomes pulsatile. This is the continuous flow. This is normal. In hypoxia, pulsation due to increased atrial filling pressure. High motility and morbidity. So this is normal. We must get a normal vein. If we get a vein like this is artery with absent diastolic flow. And here is the vein. Instead of being continuous like this, it is giving us phases. So there is pulsatility in the vein, which indicates hypoxia leading to asphyxia. It is a severe condition. Similarly, here you can see the umbilical vein at near to the urinary bladder of the fetus, and here you can see the similar pulsatility. Ductus venosus, we usually get arterial waveform here. If we go to the normal, look at this. There is no reversal. Here is the ductus venosus, and this one is the arterial waveform of ductus venosus. But here we have got reversal. So if we get reversal in the ductus venosus arterial component, it will be hypoxia. Inferior vena cava, again reversal of flow is indicative of hypoxia. So we look for inferior vena cava, ductus venosus. This is umbilical vein, ductus venosus, inferior vena cava. Human placenta, the old statement says that it is the bundle of life, the place of materno-fetal metabolic interchange. Here you can see the mature placenta and vascular supply. This is the pool of the maternal blood, chorionic villi, the uterine cavity, branch of umbilical artery. Here is the cord. Here again you can see the same things, the umbilical vein with oxygenated blood and umbilical arteries, usually two in the cord, deoxygenated blood. If we get a single artery cord, it can be an indication of a fetus having some fetal anomalies. Then comes placentation. There are hemodynamic changes characterized by differentiation of the trophoblast, migration and colonization of maternal vessels, development of a villous vascular system contacting embryonic vessels. If we look at the fetal side of placenta, Healthy Tushly villi are the basis for normal function of the placenta. So here we can see the villi. If they are healthy, that will indicate that the placenta of the fetus is healthy. There is respiratory function of the placenta also. So the oxygen pressure will be about 150 mmHg, and here it is the intravillous space. Pressure is 30 to 40 mmHg. So about 65 to 75% of oxygen saturation. Then is the fetal brain, 20 to 30 mmHg, which is about 80% of oxygen saturation. These are all blood vessels of placenta. Here you can see a diagrammatic explanation of the main stem, the primary stem, secondary stem, and tertiary stems. There are spiral arteries and spiral veins, and we have got the chorionic plate. If we look at the vascular anatomy of the uterus, there will be two uterine arteries, anterior and posterior or right and left, each dividing into ascending and descending uterine arteries. There are 8 arcuate arteries and 200 radial and spiral arteries. These are the spirals which go up to the endometrium. This is 3D power Doppler for spiral arteries. Approximately 200 vessels, terminal parts of uteroplacental circulation, blood supply of the intravillous space is by spiral arteries. By using color Doppler, we can get the precise anatomical location of the blood vessels. Here you can see the insertion, the placental insertion of the cord. We can have quantitative analysis of the blood flow, representative of physiologic changes, safe to use in ongoing pregnancy. Here is a spiral artery at 14 weeks of gestation, and this is the pattern. Now, if I ask you that look at the systolic and diastolic and give me the systolic diastolic ratio, if I don't have all these parameters, just looking at this and this, you can say that this will be about 60 to 70% of the peak systolic velocity. So the ratio can be 1 into 1.5. In this case, you can see the PI is 0.5, RI is 0.4, and it is 14 weeks of gestation. Intravillous flow here, and we can see the flow pattern. This is again the flow of the arteries. For pregnancies with impaired trophoblastic conveyor have increased risk of preeclampsia. Here you can see the spiral arteries, the basal arteries, radial arteries, arcuate artery. This is normal. Here is preeclampsia. The myometrium, and then is the decidua abysalis. So the size or the width, the caliber of the spiral arteries and radial and basal arteries decreases due to vasoconstriction and different mechanisms which can result in increased pressure and preeclampsia. The peak systolic velocity and diastolic velocity and TMV in spiral arteries higher than in controls. Why? The reason is that there will be impaired trophoblasts in vein with reduced spiral arteries diameter. So as the diameter is decreased, the trophoblastic invasion is impaired, we will have higher values, especially you can see the peak systolic velocity. Here it is the reduced diameter of vessels. This is also reduced as compared to the normal. That will end up with inadequate amount of blood with placental hypoperfusion in terms of oxygen and nutrients. This is a uteroplacental unit in which you can see the uterine vein and uterine artery. This is the area of uterus and villi. So there will be endothelial cell trophoblasts, and this is how the arteries and veins can be explained. Causes of uteroplacental insufficiency. If there is hyperactivity of synthetic nerves, insulin resistance, angiotensin, polymorphism, we will see the changes here in the uterine artery. See, this was broader and continuous. It was tapering towards the villi. Here it has constricted here. The diameter is decreased. This is normal. Look at this area and look at the hyperactivity of sympathetic nerves which affected on this uterine artery, thus causing constriction, increasing the pressure here. That will result to uteroplacental insufficiency. Uteroplacental, if there is a thrombus between the villi, then again it will be disturbed. The venous return abnormality, anatomical factor, again this is dilated vein. The blood is pooling out from the intervillous space in the uterine vein. So when there is impaired perfusion of the placenta, increased risk of placental insufficiency and fetal hypoxia is seen. We can have obliterated intervillous space. There will be reduced villus perfusion and villus collapse will result. So if there is absent and diastolic flow or reverse and diastolic flow, this is reverse. We can have perivillous fibrin deposition, ischemic villitis. After ischemia, there will be inflammation of the villi and infarct formation. So when we find arid, which is absent or reverse and diastolic flow, there are chances of these three things. Fetus with arid, AERD, which is absent or reverse and diastolic flow. ARED that indicates hypoxia changing into asphyxia, and asphyxia will cause death, will result in death because of many factors, out of which there are three main factors. Number one is there will be perivillous fibrin deposition, ischemic villitis, ischemia will occur, and infarct formations in the villi and in placental bed. The spiral normal versus spiral abnormal. Increased rate of stillbirths 0.0002. Increased rate of perinatal asphyxia is 0.01. This is the intravillous blood flow on 3D power Doppler. So measurement of intravillous blood flow may be useful for detecting the pregnancies with greater risk of fetal hypoxia. This is the blood supply, and here you can see the 3D with power Doppler showing the placental bed. Doppler is better than color Doppler. So using color Doppler flow mapping creates signals dependent on the blood flow density rather than velocity. So density is also important. It eliminates ultrasound noise, eliminates the need of Doppler. So low frequency filters are used and power Doppler is not angle dependent. Here is power Doppler with 3D flow mapping in a kidney, renal artery, and the renal flow, and this is in placenta. Here is 2D with color and 3D with power Doppler. It seems to be more accurate. 3D power Doppler and placental vessels at different stages. So is 3D really better? Yes, it is. Why? Because better visualization rate of placental vessels, easier to detect vascular branching, improvement of visualization and advancing gestation. What about high risk pregnancies? So is there a difference? Placental vascularization in preeclampsia and IUGR method is assessment of density of the placental vessels, the primary stem of the placental vessels. Why? To assess potential influence of the failed trophoblastic invasion of the spiral arteries. The importance is to see the level of vascular disturbance in PIH and IUGR in the cases of placental insufficiency. Another important issue is fetal brain development in fetuses with intrauterine growth restriction. Two important things: early onset fetal growth restriction, late onset fetal growth restriction. There are two different patterns of clinical deterioration determined primarily by the gestational age of disease onset and the placental blood flow resistance have been recently been characterized more clearly. For early onset, the early onset means that there will be 4 to 6 weeks of progression. There will be placental ischemia, fetal placental ischemia in the beginning. There will be fetal growth which is restricted, then the diminished amniotic fluid, increased brain flow in, in the brain in middle cerebral artery, cardiac ischemia, low right ventricle function. This ischemia is in Spanish because I took this slide from one of the uh, renowned Spanish professors of fetal medicine. So it's it's not that ischemia in English. Cardiac ischemia, low right ventricle function. So we can get abnormal CTG, abnormal BP, loss of tone movements, left ventricle damage. And here are the normal, then is the sparing, hypoxia, and damage. So here will be the damage. Reversal, then is the reversal, here is the reversal, and the ductus venosus, IVC, and then low right ventricle function, which will result in cardiac failure. So on one side, there will be ischemia of the blood vessels of the which are in the villi. There will be thrombosis. We will have growth restriction, then brain sparing phenomena. The amniotic fluid will decrease. There will be cardiac ischemia indicated by ductus venosus, and which can be assessed by abnormal CTG also. Then there will be loss of tone and movement, left ventricle damage, abnormal blood pressure. This is early onset, and it is 4 to 6 weeks of progression. These are the weeks, and you can see the head size. The body size tries to remain normal in most of the cases till 20 weeks in symmetrical IUGR and 28 weeks in asymmetrical IUGR. The important thing is reverse and diastolic flow and absent and diastolic flow. Then there is early onset fetal growth restriction. We need to have a prediction and prevention. Look at the flow. These two entities have two different scenarios regarding research opportunities. The first one is early onset fetal growth restriction requires over effort on prediction and prevention, whereas late onset fetal growth rate requires more effort on diagnosis of the true fetuses at risk and timely delivery. In late onset, the things are more dangerous and severe as we don't have much time to decide. If there is early onset, like in symmetrical IUGR, we will have enough time to make diagnosis, prediction, and prevention. But if it appears at 28 to 30 weeks, as usually seen in asymmetrical IUGR, which is also called extrinsic IUGR, the time is less because the things will deteriorate very quickly. Then is late onset. In late onset, we will have decreased growth, increased resistance in the umbilical artery, increased flow in the brain, amniotic fluid decreases, loss of tone movement. So some of the steps will be avoided and things that will be very quickly moving towards asphyxia. Late onset progression is 6 to 9 weeks, whereas the early was 4 to 6 weeks. This was a study on 1098 single tone pregnancies. They assessed the mean uterine artery PI 11 to 14 weeks and mean uterine artery third trimester. PI change between the first and third trimester for individual patients. They measured that for preeclampsia or fetal growth restriction. So early onset fetal growth restriction, degree of placental disease, not many changes, looks normal. Degree of placental disease in late onset, you can see the changes. Here, hypoxia adaptation sequence, fetus is going towards hypoxia. You can see the aorta and IVC. This is cardiovascular adaptation and prematurity. If there is late onset of fetal growth restriction, we will get low tolerance hypoxia, brain sparing mechanism resulting in brain sparing effect. The fetal body will be small, head will be normal. So for early onset, we need to have prediction and prevention. Whereas for late onset, we have to do the diagnosis and timely delivery. If we don't go for timely delivery, we will immediately lose the fetus.